At the outset, I would like to thank the organizing committee, Dr. Chakurkar, Dr. Lobo sir, to invite me for this talk. It is honor and privilege to actually speak after Dr. Rajapurkar sir, who has been pivotal in shaping so many careers, and I hope I can do justice to that. And we are going to move on from kidneys to something beyond kidneys now. So, being nephrologists, we always are dealing with patients with kidney failure, but there are certain organs which also require extracorporeal support, and that's where this topic comes into picture. And the more I read about it, it's actually confusing what to use when, how to use what, and the aim of the talk is just to mention out what all therapies are in use, just to see what is the available evidence for using what device in what situations. We know that liver failure is a perfect model for multi-organ system. Any liver failure, say acute or acute-on-chronic liver failure, is going to cause massive cell necrosis, sudden systemic inflammatory response. And it's all going to fall down like a domino, and it's going to affect multiple various organ systems. So it's going to cause immune dysregulation, can lead to acute kidney injury, coagulopathy, cardiovascular dysfunction, respiratory dysfunction, ARDS, hepatopulmonary syndromes, and hepatic encephalopathy and cerebral edema, which is the most devastating effect of acute liver failure. So just to give an idea of spectrum of diseases, we start with a case who is a 56-year-old male, alcoholic, cirrhotic, baseline MELD sodium score of 18, and past history significant for variceal bleeding and ascites, and is on beta blocker and diuretics, admitted for fever and abdominal pain. So he started on broad-spectrum antibiotics, but deteriorates, has hypotension, oliguria, and hepatic encephalopathy, and is shifted to ICU. The parameters worsen. The creatinine has gone up from 1.2 to 1.9. Ammonia is high, and the platelet count is low. Shows moderate ascites. X-ray shows pulmonary congestion, and he has spontaneous bacterial peritonitis. So this is one spectrum of the disease where you have a patient who has a cirrhosis and has suddenly complicated for whatever reasons, maybe a variceal bleed, maybe an infection. And then we would term these patients to have something called as acute-on-chronic liver failure. Compared to that, we have another patient who is a young male who has had an ingestion of yellow phosphorus poison. And he presents to us after 4th day with hepatic encephalopathy, with icterus, and altered sensorium. And this is another spectrum of disease where there is massive liver necrosis and fulminant hepatic failure secondary to yellow phosphorus. So first case was the patient where we used CRRT because the patient had acute-on-chronic liver failure, multi-organ dysfunction. And the second is the case where we use plasma exchange to treat this patient. So there are two different spectrum of liver disease treated with two different extracorporeal methods. Whatever you term it, eventually you have a patient who is in ICU, who is on multiple supports, who is on a ventilator, multiple infusions, multiple extracorporeal therapy, whether it is ALF, acute liver failure, or acute-on-chronic liver failure. And this is the state of the patients in ICU. So how do we define acute liver failure? It's a catastrophic syndrome without any pre-existing liver disease, which presents as coagulopathy, hepatic encephalopathy, a disease course of less than 26 weeks, and it is reversible in nature. Various systems grade it as acute, subacute, fulminant, subfulminant. Initially, it was associated with very high mortality rate, but with recent treatment and extracorporeal therapies, actually the survival rate has improved. And the mortality was primarily driven by hepatic encephalopathy and hyperammonemia in such patients. The spectrum of causes of acute liver failure actually differ from west to east. In India, the most common causes of acute liver failure is drug-induced hepatitis viruses and few other unknown causes of acute liver failure, where my patient actually come with acute liver failure and we are not actually able to pick out what is the sudden cause of acute liver failure. Compared to that, we have a patient with compensated chronic liver disease where there is no decompensation. They may have a acute non-acute decompensation in form of hepatic encephalopathy, or acute decompensation like a variceal bleed or bacterial peritonitis. And then that may progress to organ failures. So it may progress to extrahepatic organ failure in terms of renal failure or encephalopathy, coagulopathy, and then these patients would be termed as acute-on-chronic liver failure. Unfortunately, there is no standardized definition for acute-on-chronic liver failure. Various institutes define it differently. There is Asia-Pacific region, which defines it as bilirubin more than 5, coagulopathy with INR more than 1.5, and it is complicated within a month by ascites or encephalopathy. So what it includes is compensated cirrhosis, and there is no prior decompensation episode before this. Compared to that, the European and Americans define it as a presential, if patient already has a decompensation occurring associated with extrahepatic multi-organ failure, they would define it as acute-on-chronic liver failure. So what Asia Pacific excludes is patient with only extrahepatic organ failure and decompensated cirrhosis. So if patient has already had a decompensation before and is again admitted with another episode of decompensation, these are the patients which are excluded from Asia Pacific definition for acute-on-chronic liver failure. And actually this may present a spectrum of disease where Asia Pacific region probably diagnose it at an earlier stage, and with progression all other definitions come into picture. And this is important because if we diagnose it late, then we are losing that opportunity of intervention which might be important in these patients. However we term it, however we label it, basically it is a systemic inflammatory response syndrome, either propagated by pathogen or a damage associated molecular pattern associated with hyperinflammation followed by immune paresis and sepsis. Now, most of the times we think such patients are sick. There is no, if they don't have a option for liver transplant, why at all do anything? Why at all treat such patients? Now, there is no way to differentiate, short of biopsy, there is no way to differentiate a patient with liver dysfunction from, with hepatorenal syndrome from acute tubular necrosis, and such patients tend to do well after liver transplant. Also, MELD is not associated with futility. So high MELD score does not mean patient is not going to. If you can offer liver transplant to such patients, so MELD is actually predictor of mortality pre-transplant. Once they have a transplant, they generally tend to do well. So the question remains to offer or not to offer. And in such patients, the extracorporeal therapy is going to serve as a bridge to either a transplant or a improvement. And the questions we generally tend to ask is what is the short-term survival rate, or whether there is going to be a high mortality rate, the cost associated with treatment, whether it is worth it, and somebody who is taking alcohol, whether he deserves another throw at dice. So in ACLF, we know that as the grade of ACLF worsens, the mortality worsens. But such patients, suppose ACLF2 or ACLF3, when transplanted, actually lead to improved outcomes. Besides transplants, suppose you have a patient with ACLF1, they have a mortality 28-day or 98-day mortality of 20 to 40%, which goes up to 30 to 80% in ACLF2, and about 96% in ACLF3. But what studies have shown, if you can treat and downgrade the ACLF grade, by whatever method you can, then it leads to improved outcomes. So ACLF3, if within 3 to 7 days you can treat it and downgrade the ACLF grade to ACLF2, ACLF1 or ACLF0, actually leads to improved outcomes. So based on that, they devise a protocol where they assess for liver transplant. And if you have more than 4 organ failure or CLIF ACLF score of more than 64, it actually denotes a futility of care. And maybe those are the patients you should not offer this treatment. But other patients, it might be worthwhile treating them and giving them a chance if actually they are not alcoholic, and alcoholic patients are a different spectrum, and maybe that's up for debate. But other etiologies, maybe it's worthwhile treating them and seeing. So what is the goal of doing an extracorporeal liver support is to, in patients with acute liver failure, maybe recovery to normal renal function, and in acute-on-chronic, it is to get the patient back to a state which was there before the decompensation. So alternative goals will be to bridge them to transplant, prevent progression, and improve multi-organ dysfunction. And the role of extra-corporeal therapy would be to remove the toxins associated with liver dysfunction, prevent further aggravation of liver failure, modulate the immune response, support the hepatic function. Now, as nephrologists, we know that kidneys tend to deal with hydrophilic substances, and we have dialysis to remove those hydrophilic substances. So urea, creatinine, these are all hydrophilic substances we can easily remove with dialysis. The problem with liver is it deals with hydrophobic or lipophilic substances, and those toxins are generally bound to albumin. Now, when you do dialysis, the substances which are already bound to albumin cannot be removed with dialysis. So in that case, we need to target some other modalities or innovate our dialysis therapy in such a way that we can remove those albumin-bound toxins as well. They are actually small-sized molecules, bilirubin and bile acids, but they are very tightly bound to albumin, and hence normal modalities of dialysis may actually not lead to removal of these toxins. And no single device is effective, and you have to decide what are we targeting in treating such patients, and you have to choose the modality based on the target. What are the type of extracorporeal liver supports available? You can divide it into non-cell-based and cell-based. Cell-based, along with removal of toxins, it also supports the synthetic function of liver. So they have hepatocytes incorporated into the extracorporeal system that would also help the synthetic function of the liver. Non-cell-based are basically based on removal of toxins rather than supporting the hepatic system. It would include a normal dialysis that we do, which would be either intermittent, extended, or continuous. We can add albumin to the dialysis fluid and do albumin dialysis to remove the albumin-bound toxins, and that would be molecular adsorbent recirculation system, single-pass albumin dialysis, or a Prometheus system. There are various hemoperfusion techniques available. We can do a plasma exchange and few other modulations of the same. The goal is either to bridge the patient to a transplant or recover the patient to the previous state. In ALF, get him back to normal liver functions. In ACLF, get him back to a state where he was before the decompensation. And challenge is not merely deciding if it is needed. It is to decide what therapy is needed when, and when should we start it. If the patient presents, you should start it then. Should we wait for some time, start it later? That is the clinical challenge in these patients. The normal indications of RRT in liver failure still holds true. So if patient is acidotic, patient is uremic, patient has fluid overload, patient has hyperkalemia, you will start dialysis for such patients. Now, added indications or a hepatocentric indications for dialysis in such patients would be hyperammonemia, and sometimes lactate can also drive us to use renal replacement therapy in such patients. What do the guidelines say? Guideline just says that you need to use RRT based on the clinical grounds, take a judgment. You decide what needs to be done. What KDIGO says is that if the organ failure involves multiple organs, then maybe early initiation might be a better thing to do rather than waiting for such patients. We all know about initiation of RRT trials, so I'm not going to dwell into that. I'll start speaking about hepatic indications of doing dialysis in patients with liver failure. And the most common is hyperammonemia. It has a strong consensus supporting early initiation of RRT in these patients. What ammonia does is it's going to go to your brain, bind to glutamine, glutamate, get converted into glutamine, which is going to affect the astrocytes, cause cerebral swelling, cerebral edema, herniation, and is actually associated with mortality in patients with acute liver failure. Now, what we have tried doing is removing this ammonia. Ammonia is a small molecule, easily dialyzable, and to see if that reduces the risk. And yes, there is evidence that it mitigates the risk of cerebral edema. Unfortunately, there is no threshold. You do a dialysis when ammonia is more than 200, 300, 400, whatever. So what guidelines recommend is more than 100 to 150 might be a good place to start dialyzing such patients. But what matters is the trajectory of your ammonia and the symptoms of the patient. If patient has ammonia of 150 who is in hepatic encephalopathy grade 4, you still would do a RRT in such patients compared to somebody who does not have a hepatic encephalopathy. As I said, ammonia is a small molecule, so the removal of such molecule would depend on the blood flow, the dialysate flow, and the surface area. As you increase the blood flow, dialysate flow, and the surface area of the dialyzer, the removal of ammonia would go up. Can we use PD to clear ammonia? No, it is very low, and even in pediatric patients, the ammonia removal was insufficient, and hence it was necessary to augment the ammonia removal by other methods of renal replacement therapy. So a patient who has metabolic disturbance with hyperammonemia, actually we do a very high dose CRRT in pediatric patients to get rid of that ammonia. Intermittent hemodialysis can lower ammonia levels rapidly and efficiently because it's a small molecule. And within first half an hour to hour, 80 to 90% of ammonia can reduce. And this is very important to prevent brain injury. But what has been found, you do an intermittent dialysis, you stop it, there is always a rebound of ammonia levels. And that may negate the benefit of doing an intermittent dialysis. So what does UpToDate suggest is that it might be prudent to start dialysis with, say, SLED or SLED-F to begin with, get the ammonia levels down, and then switch over the patient to CRRT to maintain the low ammonia levels. Rather than just stopping the intermittent hemodialysis and waiting for ammonia levels to again go up. Ammonia clearance increases as we increase the effluent dose in CRRT. And this has been used in patients, pediatric patients with hyperammonemia, where a high dose CRRT is used to remove ammonia levels. And along with ammonia, it would also remove other inflammatory middle molecules and help in recovery of such patients. Does the modality make a difference? Should you use CVVH? Should you use CVVHD? Should we use CVVHDF? And this study shows that probably the modality used does not make a difference. You use any modality at a good dose, probably that's going to help in ammonia clearances. So then this is the trial which compared the intermittent hemodialysis with CRRT for hyperammonemia. And what they found out was that although the reduction in ammonia was significant, but the mortality benefit was achieved only with CRRT, and intermittent hemodialysis was rather associated with increased mortality in patients with hyperammonemia. So what would we do is we would start early after ICU admission for patients with hyperammonemia. Use a higher dose of CRRT compared to conventional CRRT. More probably would be CVVHDF or CVVH. And cumulative dose was the most important factor, and it was dependent on duration of CRRT rather than other parameters. And this is what the guidelines also suggest. At institution of extracorporeal support, RRT should be considered for persistent hyperammonemia, and level they have suggested is more than 100. Also, does CRRT remove ammonemia, but does it really lead to benefit in the long-term outcomes? So yeah, there was a meta-analysis and a review analysis which shows that it increases the survival in patients with acute liver failure. I could only find this one paper on online hemodiafiltration used in patients with acute liver failure. It was based in Japan, and what they found was that rate of recovery of consciousness was equally good by using continuous high-frequency, continuous hemodiafiltration or online hemodiafiltration in such patients. But I could not find any other details in this paper. So question is, if patient comes with acute liver failure, these patients benefit with plasma exchange, which we will come to later. But does only plasma exchange help, or you need to combine it with CRRT to reduce the ammonia levels? So what was found was that high volume or a standard volume plasma exchange in itself can reduce the ammonia levels in such patients. There is no head-to-head comparison comparing CRRT or PLEX for hyperammonemia, but one paper did say that reduction in ammonia was about 37% in CRRT compared to 30% in patients with PLEX between 1 to 3 hospital days. Another important factor is lactates. So most of the times we are always called ki lactates are extremely high. Please come and see what needs to be done. So one thing I need to emphasize is lactate removal is not significant with dialysis. So normal tissue clearance is 1 liter per minute, and high dose CRRT is going to only clear it by 50 mils per minute. So whatever you do, whatever dose of CRRT you use, your lactates are not going to come down because of CRRT. What CRRT will do is stabilize the patient, otherwise it will affect the cytokine removal or middle molecule clearance, maybe help in hemodynamic stability by correcting acidosis or dyselectrolytemia, improve tissue perfusion, and probably help in lactate clearance that way. But per se, it is not applicable for extracorporeal remover of lactate. So can we use plasma exchange in such patients? So this was a paper by Dr. Sarin, and what he suggests is that this is what the normal hepatocyte and your liver endothelial cell system would look like, where there is a plasma exchange or a plasma transport that happens between the sinusoids and lumen and the space of disc. But what happens in acute liver failure is your hepatocytes are necrosed, your endothelial cells are distorted, so this exchange does not happen. So it's like a crowded capillaries there, and the most important factor what was implicated was von Willebrand factor, and increase in von Willebrand factor was actually associated with high risk of mortality in such patients. So how plasma exchange is going to help is that you remove this plasma, you put in with a fresh plasma, and it's going to reduce this trophic jam that is happening at the level of hepatocyte and probably recover outcomes. So when we talk about liver regeneration, especially, for example, if patient has had a living donation, liver would regenerate. But the span for that to happen is 200 to 300. So we don't expect the liver to regenerate, causing recovery in acute liver failure. So what is postulated is probably this is the mechanism by which liver regeneration occurs in patients with acute liver failure. This is another histological slide which shows the similar phenomena. Now, what dose of plex to use? So what is higher volume plasma exchange? It is defined as more than 2 to 3-fold or more than 15%, around 15% of ideal body weight. Standard volume would be 1 to 2-fold, and low volume would be less than 1 volume of plasma. And we know how to calculate the plasma. So then the question comes, what type of plasma exchange to use? Should we use a membrane plasma, or we should use a centrifugal plasma? So there are certain differences between the two. So the duration, the extraction or the efficiency of doing plasma exchange is higher with centrifugal plasma exchange compared to a membrane plasma exchange. But when we see head-to-head, what really, does it make a difference whether you do a centrifugal plasma exchange or a membrane plasma exchange? It actually did not lead to any difference in outcomes. The only thing that was significant here was thrombocytopenia was probably more common in patients with membrane plasma exchange compared to centrifugation plasma exchange. But then again, for doing a membrane plasma exchange, you already have the machine. You just have to put in a filter and do it. If you need a centrifugation plasma exchange, you need to invest into the cost of the machine. Other advantage with centrifugation plasma exchange claim is that they can use a peripheral line, rather not require a central line. Although most of the centrifugation plasma exchange in my unit are always done by a central line, they have never been done by peripheral line. And centrifugation plasma exchange would use citrate as anticoagulation compared to membrane plasma exchange. So this was the randomized control trial by Larson, who did a high volume plasma exchange in patients with acute liver failure. And what they found is that it improved survival in patients and prevented them from going for liver transplant in such patients. Now, tolerance of high volume plasma exchange is always a question. So total adverse effects that were observed in this study was about 1/3. So 1 in 3 patients had these patients, and most commonly they had alkalosis, probably from citrate use, hypotension, and hypocalcemia in these patients. So then we thought, why not use standard plasma exchange that we are using? So use 1 to 2 volumes and see if it really makes a difference. And what was found that it compared to standard medical therapy, it achieved higher lactate clearance, higher ammonia clearance, and transplant-free survival also improved even with standard plasma exchange. Okay, let's go further low. let's do low volume plasma exchange and see. So in patients with, this was a study from CMC, and what they did was they did a low volume plasma exchange, so less than 1 volume of plasma, and added additional low dose steroid to it, and they found that almost 75% of them survived even with low dose plasma exchange. And this was the retrospective analysis of high volume and standard volume plasma exchange, which showed similar outcomes both in high volume as well as standard volume. Now, etiology of ALF varies region-wise, that's what we discussed, but most common that we see in our clinical practice is the ratol poison. And in Tamil Nadu, during the period of Jan to June, almost 450 patients in 6 districts were seen with this poison. And compared to West, where paracetamol poisoning is very common, we have this poisoning which is more common, and the ratio is 75:1. So our patients have more commonly a ratol poison compared to paracetamol poisoning. And in such patients, plasma exchange is probably the way to go. And early institution of plasma exchange improved survival rate. And it prevented these patients, even those who were qualifying for KCC criteria for undergoing transplant, almost 50% could be taken off the transplant list just with doing low plasma exchange. And it was a low volume plasma exchange. They used a centrifugation machine and just did 1 volume of plasma and used FFP and 5% albumin for replacement. Plasma exchange meta-analysis shows better survival with doing plasma exchange. And it occurs at all volumes of plasma, even with high volume, with standard volume, and even with low volume of plasma exchange. And hence the guideline recommendation from American Society of Apheresis, high volume plasma exchange is given category 1 and grade 1A, while standard plasma exchange is given 2B recommendation. So then whether combining the two would make a difference. You have a CRRT, you have a Plex. Should you combine the two for using, for treating acute liver failure? So this was the paper from Vietnam, where in dengue, acute dengue fever and acute liver failure, they tried comparing the two, and the survival benefit was better with combination therapy than doing a single therapy. So compared to acute liver failure, which is acute necrosis of liver cells, ACLF actually behaves like sepsis. So you have a liver injury, you have a systemic inflammatory response. It can go to sepsis, it can go to organ failure. In fact, SIRS can directly go to organ failure even without sepsis. Now, what is different in acute-on-chronic liver failure? This is the structure of albumin, and normally bilirubin would bind 1:1 to the albumin. What is postulated is that in patients with acute-on-chronic liver failure, they have hyperbilirubinemia. And instead of binding on one side, because of hyperbilirubinemia, bilirubin would bind to all 3 different sides where it can bind, and make the structure of albumin and alter the structure and function of the albumin. Also, in humans, albumin would be seen in 3 forms. One is mercaptoalbumin, other is non-mercaptoalbumin, which is the oxidized albumin. Now, in ACLF, what they have seen is that the proportion of non-mercaptoalbumin is high, and more than 12% actually correlates with high 30-day mortality in such patients. Also, you see nitrosoalbumin in such patients, and it directly correlates with coagulopathy. So you have albumin, but that albumin is not functional, or is rather harmful. In such patients, you keep on infusing albumin, that's probably going to cause more harm and rather than benefit in such patients. So hence the rationale for actually removing and replacing that albumin with plasma exchange in such patients. And what they found out was that it improves systemic inflammatory and survival in these patients. This is a propensity score match study from R. So with plasma exchange, there is a question whether we can tolerate it or not. So what we tried was whether we can substitute using plasma in such patients by some other methods. And that's where double plasma molecular adsorption system comes into picture. So this is how your normal plasma exchange would use like. So instead of using fresh frozen plasma, can we use adsorption method to actually replace the plasma? And this is how a DPMA circuit would look like, where the plasma is separated from the patient, goes through another pump, first into a bilirubin filter, which is the BS330 filter, From there, go into a hemadsorption cartilage of HA380, previously 330. And then you return the albumin back to the venous chamber of the previous machine and return it back to the patient before. So here what you are going to do is you are going to actually try to improve the plasma albumin clearance, toxin clearance, by using adsorption method rather than a dialysis method. And two filters are used for that. One is BS330, other would be HA380 now. And 330 has a high affinity for bilirubin and would adsorb bilirubin and reduction in bilirubin level. And HA330 would be acting like a adsorption for various inflammatory cytokines, something like a cytosorb filter. And what they claim to reduce is inflammatory markers along with liver enzymes, bilirubin, bile acids. And you add a dialysis filter to it, you also would get a clearance of small molecules. The advantage is there is no need to replace the plasma with albumin or FFP. And after adsorption, the purified plasma is returned back to the patient. You don't need any special apparatus for that. You can use it on normal CRRT circuits where you can join the two filters extracorporeally. This is what we had done in our unit, where you have a dialysis machine. So the blood would come through the patient to the dialysis machine, go through a plasma filter. From the plasma filter, from the effluent disk, it goes directly through another pump. Then it would run through your BS330 filter, HA380 filter, and would return to the venous chamber of the first machine and return back to the patient. And a propensity study shows that the reduction in bilirubin and bile acids is similar to using a therapeutic plasma exchange, but the loss of albumin is much lesser, and the safety is better with using DP mass compared to a plasma exchange in such patients. This was a comparative analysis where they compared hemadsorption with therapeutic plasma exchange, and they found that probably reduction in bilirubin and bile acids and survival was best with DP mass compared to plasma exchange, and hence they probably said that the choice should be a DP mass in patients with ACLF vis-a-vis plasma exchange. So then can we combine the two? So this is the study which said that probably combination works the best. You can use half the dose of plasma exchange along with DP mass to see if the survival improves. Is there a role of cytosorb in this patient? So what cytosorb studies have shown is that it reduces inflammation, it reduces bilirubin, but it also reduces platelets and fibrinogen. And the outcomes are not very different between the two. In fact, the latest meta-analysis in sepsis patient proves that cytosorb is causing more harm rather than benefit in such patients. But if you want to see, look at it as only adsorption method compared to, say, combined plasma filtration or Prometheus, then probably cytosorb gives the best result in reduction of bilirubin and bile acids. This is the meta-analysis which compared various adsorption techniques like Auxeris Jaffron absorption, that is the BS330 and HA380 filter, with heme adsorption. And what they found was that it had that there is a difference in bilirubin, the creatinine levels are better, the liver enzymes reduced, vasopressor requirement reduces, the inflammatory markers are less. But they could not comment on mortality benefit of such patients because the data was so scarce that they could not really come to an outcome. And what they therefore suggested was the better clinical trials and more research to recommend one over the other. So if one mode is not working, should we combine various modes of dialysis to see? So what they did in this paper was compared various modes of dialysis based on the need of the patient versus using a single mode of dialysis. For example, if patient has hepatorenal syndrome, they were started with plasma exchange compared with hemofiltration first. Suppose if before the second treatment the renal functions had improved and the main problem was hyperbilirubinemia, then they combined plasma exchange with DP mass rather than a renal replacement therapy. And what they found was that probably mortality rates were better with combined mode of therapy rather than using any single mode of therapy.
Manan, can we?
Last 3, 4.
Yeah.
Yeah. Other is whether we can use albumin in the dialysate site to remove the toxins that are bound to albumin. So this is a study for single pass albumin dialysis. So this is fairly simple but very costly. So what you need to do is just add albumin to your dialysate fluid in the CRRT. So what studies have shown is the optimum concentration that is required is 3%. Higher than 3% actually does not make any benefit. So you need to add a 750 ml of albumin to a 5-liter bag of CRRT circuit to have this. And there are no randomized control trials, but other case reports have shown that there is a reduction in bilirubin and other toxins associated with. And we Indians, we always like to reduce the cost. So this was a study from South India where they, instead of using albumin, they tried using FFP. And what they found out was that bilirubin was lower, but it did not lead to any benefit in terms of mortality. MARS, it is similar to single pass albumin dialysis. Single pass is the albumin goes waste. You're not regenerating that albumin. In MARS, you're trying to regenerate that albumin to use it again. And the RELIEF trial said that there is no clinical benefit. Similarly, FULMAR trial also said there is no clinical benefit. Meta-analysis showed that there is no clinical benefit, but if you do high-intensity MAS, probably there is some benefit which is expected. Prometheus is similar where there are two circuits. One is the dialysate circuit, and one is the albumin circuit. And Helios study did not show actually any benefit. And so we have various dialysis that are available. The point is when to use it. So probably the time to initiate or when do we start dialysis matters. Early initiation would probably lead to better benefit in this patient. But offered too late, it will reduce the benefit. You start too early and those interventions are not needed. This is something which was tried in patients with cirrhosis where we did a ascitic. This is not my paper. This is by Girish and Mahesh, dear friends. What they did was they removed ascitic fluid and they ultrafiltered the ascitic fluid in itself. So they chose 12 patients and they bypassed the blood camp and they kept the dialysate off and they targeted 3 to 4 liters of ultrafiltration of ascitic fluid. And actually 5 patients did well. They had good urine output. They were off diuretics and better renal functions. 2 patients required longer or are still on ascitic fluid ultrafiltration and needed a Tenchkov catheter placement. Hospital visits reduced for patients' quality of life was better, and there was no adverse effect. So the take-home message is stop asking which device is the best. Better to ask what problem am I treating, and probably titrate your therapy to a toxin that is implicated in such patients. And unlike renal failure, liver failure has 2 types of toxins, both water-soluble as well as albumin-bound. And for hyperammonemia, probably CRRT is the best thing to do. Therapeutic plasma exchange is the only modality with consistent and high quality evidence. And although theoretically Mars and Prometheus devices should work, they have actually not made any benefit in clinical studies. Thank you very much.
Thank you, Manan, for the talk. Chairperson's comments.
Extensive talk. Actually, I learned quite a lot. The only 2-3 things is that low plasma exchange that you quoted from CMC were lower. The steroids were not used for rodenticide, it was used for alcoholic hepatitis. The rodenticide, they had used only a low volume plasma exchange. And the low volume plasma exchange, you don't know whether the steroid worked well or the plasma exchange worked well. Well, we have a protocol here that if it is ACLF, then we start doing the CRRT at probably around 150. The ALF patients, we are a little more relaxed. We start doing it at around 200 to 250. Of course, we look at the grades and the albumin, the ascitic fluid dialysis that you showed. So we have a couple of patients where we did PDs in them. They did well for some period of time, but of course, no mortality benefit was achieved. Yeah. So, and all of these work only as a bridge therapy. The only where Plex works really well are atol poisonings, and of course drug-induced. So in India, the most common are AKT, that's the CMC Vellore paper, followed by the CAMS. So that's where probably we'll try the plasma exchange, otherwise no.
My question will
Probably
be
acute hepatitis as well is one scenario where plasma exchange would also give a...
Yeah, so there is a good paper from Dr. Shah from Global Hospitals where they have a case series of probably 21 hepatitis E where they have had good results. So yeah, so acute viral hepatitis also it might work well. So hyperacute is where it works well.
My question would be, when do you, what parameters would you consider to start plasma exchange in ALF?
Ammonia, and rather than only looking at the parameters, what they have found is that doing early plasma exchange in that in those patients probably gives a better benefit than waiting until the worst parameters set in, like hyperammonemia or high lactates and encephalopathy. So before those things happen is probably the time where plasma exchange would work the best. So probably even if the patient has normal parameters, maybe it's worthwhile doing a plasma exchange if there is a good evidence that they have consumed a high dose of ratol poisoning. So in acute liver failure, probably arterial ammonia best correlates with hepatic encephalopathy. In ACLF, frankly, ammonia levels they don't matter very much unless you know it's so acute that patient is encephalopathic and you want ammonia levels to go down by using extracorporeal therapies. So in that, probably venous can be used as well. But in acute liver failure, arterial ammonia correlates best with hepatic encephalopathy.
When should we consider this yellow phosphorus poisoning patients for transplants? Because if you do plasmapheresis, their INR comes down. Their supra-urgent listing.
Yeah, so you list all the patients. That is the protocol. So any acute liver failure who qualifies KCC criteria have to be listed for a transplant. But until they get a transplant, you try plasma exchange. Once, if they improve, which this study showed that probably 75% improval with plasma exchange, you delist them. If not, then they go for transplant.
Actually, ratol is the only poisoning where you are very, very upfront and you want to do that plasma exchange fast because that's where it works the best. The rest all cases it doesn't work.
What happens, like we do plasmapheresis today and tomorrow INR comes down and then the listing, supra-urgent listing, they are not
No, the supra-urgent listing is on the first INR. It is not post-plasma exchange.
So it is before the plex INR
the
that matters.
listing doesn't depend on the second day, isn't it? You listed yesterday, no? The listing will remain for 7 days. So your patient is active on the list for 7 days. And after 7 days, also sometimes we allow re-extension, provided you provide the clinical details, and if it is justified, the expert committee allows you to extend beyond 7 days. But once you list, the patient is active, whatever happens, whether he improves, unless you have a patient who clearly improves and the treating team wants to delist.
Yeah.
First of all, you don't get organs on super urgent list. It's very rare that you get them, and the listing doesn't change as per the second INR.
Yeah, corrected INR.
Not as much as we would want, sir.
Please.
Not as much as we would want.
So yes, ALF, you know, ALFs do get parity. There is no doubt that they get
We need
organs.
more, sir. We need
have
more.
to have a suitable donor. Sometimes the treating team refuse a donor because of reasons like size mismatch and things like that. Or if it is a marginal donor. Of course, all ALF treating teams want a good donor, not extended criteria or marginal donor.
But, retrospectively, when I think whatever acute liver failures I've treated in past a year or so, actually a lot of patients have come out with plasma exchange, especially in retol and hepatitis or any infection related, and they actually do well with plasma exchange. I've combined CRRT for few patients, so plasma exchange plus CRRT, and actually they get delisted. Maybe at least maximum.
That's why Vipul has called Atul over here, so that the listing can be modified.
What is the duration of the DP mass? I mean,
so it again depends on the volume of plasma you want to treat. So it would work like a plasma exchange. Only thing is I run the pump second pump at 30 mils per minute. So calculate the plasma according to that, and depending on number of volumes of plasma you want to run, you can run it. The company quotes it to be 8 hours, and after that probably you need to change before the adsorption capacity is exhausted.
so it is based on the saturation.
Yeah.
So but that time, if we are So if we are able to give less plasma volume, like instead of 30, if we keep it 20, then can we extend the duration, or does it really affect?
Eventually, the adsorptive capacity remains the same.
So is there a way to assess it?
No. You have to go by what company people say. There's no way you can
So target like plasma volume, which we can control.
Yeah.
How many days would you continue plasma exchange or CRRT if the patient doesn't improve, especially ACLF?
So that is clearly suggested by the grading. If your patient is worsening, suppose you start a therapy at ACLF grade 3, you are able to do good by downgrading the ACLF growth, then yes, probably those patients are the ones who are going to benefit. But if your patient is not going to improve, despite all these therapies, you have more than 4 organ or 3 organ failure, patient's score is, Cliff SOFA score is more than 64, or ARC score I think more than 12 or something like that, then it is a futility of care. Then you really need to go and speak to the patient that probably all this is not going to make a difference, especially if there is no transplant in the pipeline. Suppose if they have a transplant, then probably optimize and then go ahead with a high-risk transplant. Anyways, with that score, the mortality is going to be high, but then you at least would give some survival benefit with transplant compared to all these modalities.
There are a certain subset of sepsis patients who do not have frank liver ALF, but they develop hyperammonemia. What would be your threshold of treatment there, and what modality?
Modality probably would be CRRT, especially in sepsis, where I would give some convective and middle molecule clearance benefit along with a small solute clearance as well. As per the threshold of ammonia goes, there is no guideline or no recommendation as such. Mine would be somewhere around 200. Anything above 200, I would think of doing it, especially if it's associated with encephalopathy or neurological dysfunction.
There's no, and is there any guideline? How rapid lowering of ammonia do we require?
As fast as possible.
As fast as possible.
So some people recommend that you start with intermittent hemodialysis, because that's the best modality to reduce. So best modality to reduce ammonia would be a rapid dialysis, as like all small solutes. The problem with intermittent hemodialysis is the rebound that can happen when you stop the intermittent hemodialysis. So when I was going through UpToDate actually recommends that patients with hyperammonemia, you start with standard hemodialysis first, reduce the ammonia to some respectable level, and then after that, so that rebound does not happen, switch those patients to CRRT so that you can maintain the low ammonia levels in such patients.
How often have you seen the worsening of cerebral edema when there is rapid lowering of this ammonia?
No, it improves. It improves. Because, yeah, I'm talking about ALF, yes, ALF.
That's why I asked the first. Started off in sepsis patients.
Yeah, ALF.
Thank you, Manan, for the
Thank you.
talk.
Thank you.
And thank you, Sahil, for the sharing.